afternoon, and welcome to City Club of Portland Friday Forum. City Club is where we bring civic-minded people together to make Portland and Oregon a better place for everyone to live, work, and play. I'm Karen Curvin, president of City Club, and I would like to welcome members and guests alike, those of you who join us today at Sentinel Hotel, and those of you listening on OPB Radio or watching on Portland Community Media. The generous support of City Club's corporate and media partners ensures we put on the state's best civic programs week after week. I'd like to thank our media partner, Oregon Business Magazine. Our current Friday Forum sponsors are Bank of the Cascades, Family Healthcare Plans, Legacy Health, Russell Fellow Properties, The Standard, and Stoll Reeves. We are grateful for your support and commitment to City Club's mission. Please join me in a warm round of applause for all of them. Next week, we will host the State of the City with Mayor Charlie Hales. Not surprisingly, this event is sold out. You can learn more about club events, purchase tickets, and become a member on our website, pdxcityclub.org. As always, we will be live tweeting today's program. You can follow along and join the conversation using the hashtag PDXCityClub. After our program, I will facilitate a question and answer session with the audience and Dr. Hood. Members, please come to the microphone to ask your questions. And for all of our audience members, please locate the index cards on the centers of your tables and write your questions on them during the forum. Hold your cards up high, and City Club staff will collect them prior to the start of Q&A. And now for our program. Chronic diseases such as heart disease, cancer, diabetes, and asthma are the leading causes of death and disability in the United States and disproportionately affect communities of color and low-income populations. When we look at inequality in Portland, in Oregon, and around the country, little feels more relevant and pressing than unequal outcomes in health and expected lifespan from one part of our community to another. Today, we hear the first of three programs that come at this topic from different vantage points. Join us again on March 6th and April 24th to continue the conversation. To say that today's speaker has been a pioneer in the sciences is a dramatic understatement. Dr. Leroy Hood was part of the original team of scientists who mapped the human genome, where he developed the core technology needed to accomplish that task. Hood has made many seminal discoveries in the fields of immunology, neurobiology, and biotechnology, and most recently has been a member in the development of systems biology. He is one of only 15 individuals elected to all three national academies, the National Academy of Science, the National Academy of Engineering, and the Institute of Medicine. Hood has founded or co-founded 15 different biotechnology companies, including Amgen, Applied Biosystems, Rosetta, Darwin, Integrated Diagnostics, and Indy Molecular. Dr. Hood works in partnership with the M.J. Murdoch Charitable Trust. Please join me in thanking the Murdoch Trust for making this program possible and in welcoming Dr. Leroy Hood.
Well, thank you very much. It's a pleasure to be here. What I'd like to talk about is an absolute revolution in healthcare that's coming. And the essential message is that healthcare really has two components. There's a component of wellness, and there's a component of dealing with disease. And what I'd like to do is briefly tell you about the journey I took in coming to insights and how we are going to transform healthcare in the future. I remember being a young assistant professor at Caltech back in 1970, and realizing that both biology and disease were enormously complex, and we needed new kinds of thinking to attack that complexity. And the new type of thinking that emerged, and it took a fair amount of time, was something we call a systems approach to complexity. So to explain it very simply, imagine the fable of the elephant with the 6 blind men, and each of those people feel a different part of the elephant, and they think they have the essence of the elephant, the tail, the trunk, the leg. And what a systems approach to understanding the elephant would do is combine all of those observations together to give an integrated picture of what an elephant was. But what was really clear at that time is we didn't have the means of thinking about complexity. We certainly didn't have the technologies and the appropriate analytic tools. And it was 3 or 4 years later, I remember reading a book that really transformed my life and how I thought about this kind of problem. And that was a book by Thomas Kuhn called The Structure of Scientific Revolution. And it was about paradigm changes in physics. So a paradigm change is something that transforms how we think about a particular area of science. And he pointed out that paradigm changes were enormously difficult to achieve because scientists in general are enormously conservative, and they like to hang on to what has come before. So I had the good fortune over the next 40 years or so to participate in 5 paradigm changes that on the one hand dealt with complexity, and on the other hand led to this whole new view of medicine we'll be talking about. So the first was we developed 6 instruments. We brought engineering to biology that allowed us to basically read and write DNA and proteins. And the significance of that bringing engineering to biology was it enabled high throughput data gathering and the big data that's an essential part of contemporary medicine. The second paradigm change came as a result of one of those instruments, the automated DNA sequencer. That enabled the Human Genome Project. I remember going in 1985 to the first meeting ever held on this topic with 12 others to decide whether or not this was a feasible approach forward. And I think the most significant observation was we decided it was, but we were split 6-6 on whether it was a good idea, and those opposed were really against it. And over the next 5 years as we went out into the community, I would say initially 90% of the biologists were against the Genome Project, and the National Institutes of Health was really against it. But this all changed in time. A third paradigm change came from developing the automated sequencer, where I had to bring together expertise in computer science, engineering, chemistry, and biology. And the realization that in the future, departments of biology should be cross-disciplinary. They should bring together all the flavors of scientists and let them work effectively where leading-edge biology could drive the development of relevant technologies, and in turn, they could pioneer the development of good analytic tools. And I tried to persuade Caltech that this was a great thing to do, to have a new applied biology department, and failed. But Bill Gates made it possible in 1992 to move to the University of Washington, where we set up the first department, molecular biotechnology, that was cross-disciplinary in nature. And it was spectacularly successful in many ways. But after 8 years at the University of Washington, I had been all along negotiating to create an institute to do this systems biology, I realized that the bureaucracy of state universities was so rigid that it wouldn't permit many of the essential things that needed to be done to create a systems biology institute. So I resigned and then started the Institute for Systems Biology in the year 2000. And it pioneered systems science and a systems approach to disease, which was, of course, the fourth paradigm change. And the fifth was the application of systems thinking to disease leads to systems medicine and something I'll describe later called P4 medicine. And that's where we really began to understand the revolution that would be coming in the next 10 years or so. So the Institute for Systems Biology had the enormous good fortune, or I should say I had the enormous good fortune, to meet the Minister of Economy for the state of Luxembourg in 2007. And he was interested in transforming the economy in Luxembourg from a 90% dependence on financial manipulations and so forth to bring in biotech and medical sciences. So he asked us to put forward a proposal that would enable them to do so. We did. We were awarded a $100 million contract over a 5-year period, and we used that money in an enormously flexible way to take the most daring ideas we had to develop the strategies and technologies for systems medicine. We developed approximately 10 of these, and that placed us at an incredible tipping point. And that tipping point led to the insight that medicine in the future would be the 4 Ps, that is, predictive, preventive, personalized, and participatory. And the 4P medicine, I want to emphasize how different it is from the contemporary medicine that's practiced out there in 6 different ways. 1, it is focused on the individual, not on populations. 2, it's really focused on wellness rather than primarily disease. 3, it's all about creating data clouds for the individual of many different types of data. In fact, data clouds that have billions of different features in them. So we define with enormous precision what each of us are, and we have the computational tools to be able to analyze that information so as to create what we call actionable possibilities. That is, recommendations for you personally that if you follow them will allow you to optimize wellness and minimize disease. Yet another feature of this new medicine is the idea that the way we do clinical trials today is all wrong. We put 30,000 patients together in a big population, and we give them a cancer drug or a placebo, and we abstract from their responses curves that tell us how things behaved. And the curves allow you to say, 1, did the drug work to a certain extent anyway, and 2, how does the population average respond to that drug? What's wrong about that view of medicine is each individual is unique genetically and unique environmentally, and you can't average them. So what P4 medicine does is to analyze each individual data cloud, and after we have a sufficient number of patients, we can aggregate patients with characteristics we're interested in into groups that will allow them to respond to appropriate drugs and things like that. Fundamental change in how we do clinical design. And the fourth feature, the sixth feature of P4 medicine is the idea that a fundamental part of this medicine is going to be patient-driven social networks. They're really critical for, 1, learning about the new kind of medicine. 2, they open up the possibility for crowdsourcing and having patients work together to figure out how to optimize their own health. And 3, these networks in the future will be the opening wedge of advocacy to force a change on a system that is basically quite conservative, and physicians themselves are quite conservative. So social networks will be key for the future. So if you look at it in a broader sense, P4 medicine really has 2 major thrusts. One is the thrust of wellness, the other is the thrust of disease. And what I will say is 98% of the resources we bring to healthcare today go into disease. Very little goes into wellness. In fact, wellness has a somewhat dubious kind of reputation. And I'm going to argue P4 medicine is going to put an enormous focus on medicine, and it is going to do what is absolutely essential to making wellness legitimate. Namely, we will create metrics that will allow us to measure your degree of wellness and to optimize it. And I'll say a little bit more about that in just a moment. My prediction is, over the next 10 to 15 years, these 2 sections of P4 medicine, wellness and disease, will emerge to become discrete, separate industries. And, of course, disease is the contemporary healthcare system as we know it today. And my further prediction is, in 10 to 15 years, the market cap of wellness will far exceed the market cap of the disease industry. And, in fact, the wellness industry will do 2 revolutionary things. One, it'll allow us each to optimize our wellness, that is, to optimize our potential human capital, to optimize our physiologic ability to respond to our environment, and our mental ability to respond to our environment. But the other thing that's really key about wellness is that for the first time gives us the ability to study disease correctly. The way we study disease today is we wait until you're sick and we study the sick people and we try and understand what makes them sick. But if you want to study disease properly, you want to look at it right at the point of transition from wellness to disease. And studying well populations will let you do that. And I'll talk more about that in just a moment. So why do I make such an emphasis of wellness? Well, if you take into account the increasing degree of average lifespan that's occurred over the last 20 years or so, you can make an absolutely astounding extrapolation. And that is the idea that 50% of the kids born this year will live to be 100. So the question is, what is the quality of their life for their last 20 or 30 years? Will they be alert mentally and physically, or will they be like many of the people we see today? And that's why wellness is absolutely fundamental for the transition. So I started thinking probably 5 or 6 years ago about how would it be possible to bring this vision of P4 medicine to the healthcare system. And what we decided about 2 years ago, a little more than 2 years ago, was that we would put forth a vision that we could have a pilot study that mimicked all the fundamental features of P4 medicine, in which we would do a longitudinal digital age study on 100,000 individuals who were well. And let me talk about just what that means. So how would we do this longitudinal study? Well, we'd make measurements on them to create data clouds for each that were dynamical. That is, that were corrected against reality every 3 months. We would do the whole genome sequence, and then we'd analyze blood and urine and saliva, and we do clinical chemistries and analyze proteins and analyze metabolites, we would actually, every 3 months, sample your gut microbiome. These are the microbes that live in your gut and have an enormous influence on your wellness or on propensity to disease. And then finally, we do more frequent measurements, self-measurements, using things like the Fitbit to measure activity, quality of sleep, and then we do blood pressure and weight and pulse and all of those things. And the idea was, for each individual, we would have 1 billion or more data points, and if we had the proper analytic tools, we could extract the actionable possibilities that would allow you to optimize disease, optimize wellness, and minimize disease. But if we think about this project in a little broader context, you immediately see what I meant about wellness being the key to understanding disease. Because if you had 100,000 individuals and looked at them, say a year or 2 years after you began the study, every 3 months or so, we would be able to divide that population into 2 groups. So one would be the group that maintained their wellness or actually improved their health and everything. A second group would be those that transitioned into disease. So let's talk about the first group, those that maintained their health. And I'd say 2 things about that, and we can make generalizations now. Imagine that each of you has a virtual wellness well right beside you, and that most of us, frankly, are right at the bottom of our wellness well, and if we act on these actionable possibilities, we can bring us right up to maximize our wellness and minimize our disease. And what is really critical about that is, to do that, we have to be able to create blood metrics that will let us assess where you are in your wellness well. And I'll just say, in studies that I'll talk about toward the end, we've analyzed 107 individuals, and we're already beginning to put together the blood metrics that will let us make wellness measurements. And these are really important measurements because they will allow us to deconvolute both physiologic wellness and psychologic wellness. And we'll be able to come to understand their interplay in really interesting ways. Now, with regard to the second group that has started to transition into disease, what we can do is follow their 3-month data tranches back to the point where the disease divergence occurred. We can use systems approaches to come to understand the basic mechanism of that earliest part of disease, and we can develop early diagnostics and therapeutic approaches that will let us then aid in transitioning the individual from the wellness trajectory, from the disease trajectory, back to the wellness trajectory. And when we do so, we save society all of that downstream part of the trajectory that would have cost dollars to deal with chronic disease and things like that. So from the data clouds, we can extract the actionable possibilities. We've done 2 really important things that are incredibly important for changing behavior and persuading people to take on these actionable possibilities. One, we've hired coaches that understand deeply what the issues of wellness and disease are, and who can individually talk with the people about their own wellness state, what their actionable possibilities are, and what they should do in the context of what their objectives for health actually are. So just explaining things to people and encouraging them is one fantastic motivation for changing behavior. But a second motivation is you can allow them to see the data cloud for the next data gathering after they've made an actionable decision, and you can show them where the data cloud has moved in exactly the right direction to take you to optimize wellness and or to minimize disease. So what we plan to do, 100,000 is an enormously ambitious number, is this year to do 100 individuals, and we have done that. We'll talk about that in just a minute. The next year we'll do 1,000 to 5,000. The following year we'll do 10 to 20,000, and finally get up to 100,000. But what I'd like to talk about now is the study of 100 pioneers that we began this March. We've gone through 3 distinct data gatherings, and it's now, this study is at an end. Roughly 10 months later, we've analyzed the data, and I can say the results are spectacular beyond our belief. But let me give you examples of the kind of things we've observed. Number one, remember that we selected these people because they testified, each of them, that they were well. So we saw that 91% of these well people in the first blood analysis had major nutritional deficiencies that could be corrected. We saw that 68% of them had major inflammatory challenges. Some were minor, some were really major, that could be corrected. We saw that 52% of them were heading toward diabetes. And in fact, what we can say is there were individuals that were frankly pre-diabetic that in that 10-month year, have now been brought back to normal. So I'm striking observations. And the basic bottom line is, after we got all done, each of these 100 well people have multiple actionable possibilities they can use to improve their health. But I'll give you several other examples. We observed that 3 of the 100 individuals had excessively high levels of mercury. And this is a typical yuppie example of wellness. It turned out that all 3 ate excessive amounts of tuna sushi. And the first one who responded substituted salmon for tuna sushi, and in 2 months, his mercury level was half what it was before, and in the third tranche, they're back approaching normal. So be careful about eating fish, cooked or not cooked, that are at the high end of the food chain in the oceans, and tuna is one of the worst. Another observation we made is 3 of the individuals had excessively high levels of lead, and this is really dangerous because it doesn't go away easily. And the worst one by far was, and where that came from is an intriguing study. We're doing an N of 1 study on this person, trying to assess where all this lead came from. But he's now under chelating therapy to remove the lead from his body because it causes neuronal loss, so you don't want to have high lead levels at all. But another area that shows the interesting interplay of the genome with nutritional deficiency is we observed that 90 of the individuals in this cadre were deficient, and some really deficient in vitamin D. And I'll say, vitamin D deficiency is nothing to fool with. It causes neurodegenerative losses. It gives you difficulty in bone maturation, and that it can cause really severe asthma, especially in younger people, and on and on. So it's very easy to say, well, this is Seattle. They didn't have vitamin D because they never saw the sun. But it's much more complicated than that, because it turns out when we did the genome sequences, we knew that there were 6 variants in 3 genes, and each of those 6 variants blocked in different ways your ability to uptake vitamin D. And what we were able to show beautifully in the first tranche of data, if we bin the patients into those that had 5 or 6 of these deficient genes, those that had 3, or those that had one or two, there was absolutely a linear distribution from low to high of vitamin C. And even more, those individuals that had multiple deficient genes required enormously more doses of vitamin D to elevate them back to normal than did those that did not. So you need the genetics as well as the environmental measurements to really do things well. And we could show that for cardiovascular disease. We could show that for a whole variety of other diseases. But the bottom line was, again, all of the 100 individuals had multiple actionable possibilities. I would say the 100 pioneers have really learned two very fundamental things from this study. Number one, your genes control your potential. They don't control your destiny. In most cases, if you're determined to change your behavior, you can work around limitations your genes have imposed on you. And I emphasize most cases. There are some things that's not really true for. I think the second thing that we observed was almost everyone realized from this study what is really key is to realize you have to be responsible for your health. You're the one that can really optimize your health. You can't go to doctors who look at patients in terms of population averages. You have to understand what you are and what your dynamic data cloud are all about, and you have to act on the actionable possibilities that you have. And I would say almost all of the people in this study want to go on and continue in the next study. So let me say, I think with regard to healthcare, this study is really going to be transformational. Number one, we're creating for the first time a catalog of all the actionable possibilities that will be useful for all of us as we move into wellness studies. Number two, we're developing the analytics so we can take your individual data cloud and we can integrate and model that data so we can come out with actionable possibilities that you can use to improve your health. Number three, we've already begun to discover sets of molecules in the blood that almost certainly will be the fundamental metrics of wellness that will allow us both to measure psychological as well as physiologic aspects of wellness. And number four, we're beginning to see really interesting disease transitions. For example, the most common genetic disease in Caucasians is a gene defect called hemochromatosis, and that leads to a buildup in the blood. And if you have two bad copies of this gene, what happens is the iron begins first to destroy your pancreas, leading to diabetes, then your liver, leading to liver cancer, and finally, it leads to cardiac decompensation. Most frequently, hemochromatosis presents by the cardiac failure, so it means you're already a chronic invalid for the rest of your life. We discovered 2 of the 100 individuals had 2 bad copies, enormously high iron levels, and they're very actionable. You bring them back to normal just by bleeding initially every 3 or 4 weeks, and then later you can probably do it every 6 months or so. But we have done 2 important things. One, this individual is safe. Neither of them had any damage with any of those organs, at least that we can discern at this point in time. And even more important, they've both gone back to their families to have them tested so they can see whether there are family members that they have to worry about as well. So that's a really beautiful example of the earliest disease transition, which really got reversed. But if you want to calculate cost savings for healthcare, just figure out how much it costs to treat someone with chronic hemochromatosis for the last 40 years of their life, and all of a sudden, you don't have to do that. So those are the kind of savings that you can see. Another area that's important is we're creating a database from which we can create companies that will foster this whole new wellness industry. And I'll just say, I'm really excited about the possibility of making the Northwest a center for this new wellness industry. So I think Portland should figure out how to join the bandwagon and get involved in these kinds of things as well. And the final thing that I would say is we are now working on new kinds of blood and urine and so forth measurements. And what we want to be able to do within a 5 to 10 year period is transfer all of the measurements into your smartphone, be able to take a droplet of blood and make all the measurements you need from that. And it means you have an at-home assay that you can then broadcast to an analytic center, and they can identify your actionable possibilities, and we'll tell you ways that we can go about doing that. But the final point is, what I've described has all of the 4 Ps we talked about earlier, and it's the opening wedge for bringing P4 medicine to the healthcare system with the ability to improve your health, with the ability to significantly decrease cost, and with the opportunity to create innovation. That's really going to be transformational. But let me just say, I think it also has some broader societal implications that are intriguing. What the things I've done are going to do is lead to a digitalization of medicine, that is, smartphone assays, and many other things that we haven't talked about. And the reason that's important is it's the digitalization of medicine that will be one of the driving wedges for the democratization of healthcare. And